Okay, good morning, everyone. Why don't we go ahead and get started? So today we have a very distinguished speaker, Dr. Eddie Cornwell, who I will introduce formally in a couple of minutes. But I am so happy that he is our Swan Visiting Professor, which is our most distinguished professorship of the year in the Department of Surgery at the University of Colorado. We are here to celebrate the life and the legacy of Dr. Henry Swan. And I have a photograph of him in his office. He was a native of Denver, and he graduated from Williams College, magna cum laude, and was captain of the tennis team. He then went to Harvard Medical School, where he graduated #1 in his class. He then came back to Denver and worked at Denver General and actually started a pathology residency and decided to switch over to surgery. He then went to Boston and worked at the Brigham and Boston Children's, where he did his surgical residency. That was at the time of World War II, and in 1942, he enlisted in the Army. Because of his medical training, he was sent to Europe and rose to the rank of major and led a surgical team in Europe. He then came back to the University of Colorado in 1946 as an assistant professor and was appointed chair in 1950, 4 years later. So I think that's one of the fastest ascensions I have ever seen. He was the first full-time chair at the University of Colorado, and he really ushered in the age of cardiac surgery with his work on hypothermia and its application to cardiac surgery. He brought world attention to the University of Colorado with his work on thermoregulation and early cardiac surgery. He was also a very avid flyer and outdoorsman, and I think he survived 3 plane crashes and did not necessarily walk away from them all, but did survive and continued flying. He made so many contributions to surgery and to the Department of Surgery at the University of Colorado, and he passed away in 1996. He's survived by his wife, Jerry Swan, who I've had the pleasure of meeting multiple times and having dinner with her. And of course, it is very fitting that we have Dr. Edward Cornwell here as our Swan Visiting Professor. If you read through the list of previous Swan professors, you can see that it represents the best of American and international surgery. He's a native of Washington, D.C. He attended Brown University as an undergraduate and then went to Howard University for medical school. He graduated AOA and class president. He received his surgical training at LA County and then attended Maryland Shock Trauma for his tax fellowship. He then went on faculty at Howard University and then back to University of Southern California. I first met Dr. Cornwell when I was a newly minted attending, and he came as the inaugural chief of the Trauma and Acute Care Service. And, honestly, I think we were winging it at Johns Hopkins University, and he really led the first major organization of our trauma services and critical care services, which absolutely resulted in so much better care of our patients. He was then recruited as chair of surgery at Howard University. Dr. Cornwell has led multiple national organizations, including president of the Society of Black Academic Surgeons and is president-elect of the Southeastern Surgical Congress. He has had a lot of effort and has had seminal work in education, outreach, and particularly violence prevention. If I were to read all of his local and national awards, I would probably take the rest of the 55 minutes that we have left for this grand rounds. He's received teaching awards at every institution he has been at. Dr. Cornwell is really a great friend. He's a great leader. He's a great surgeon, researcher, and teacher. And I am so grateful for all of his teaching and his mentorship especially very early on in my career. And with that, I turn it over to Dr. Cornwell. Thank you so much.
Well, good morning, and thank you, Dr. Schulich. It's as I share my screen here. Can you all see my title slide?
Yes.
Yeah. Well, I hope the residents have already inferred the first lesson of the day, which is if you're going to get introduced, have a great friend introduce you. Dr. Schulich's obviously been talking to my mother, and I appreciate it. I'll get over the overly generous presentation. A true honor indeed. Today's discussion is going to be around outcome disparities, but outcomes is what all of us have been about from the very earliest days of surgery, community surgery, academic surgery, teaching and training. Our activities are always centered around the patient, and I'm going to use that in the spirit of the honor of being able to give the 40th annual Henry Swan Lecture in honor of your first full-time academic chair, discussing outcome disparities following trauma. Who, why, and when. And Dr. Schulich, as he mentioned, we were faculty colleagues at Johns Hopkins, and the chair that inherited me, Dr. Julie Freischlag, organized a retreat shortly after she arrived. And I've borrowed the theme of her retreat in many of my talks, which is what makes you excited about coming to work. Let me just make sure I'm able to advance my slides. There we go. And so I'm going to begin by telling you that I'm an unapologetic cheerleader for this discipline we call outcomes research. Because as I hope the case I exemplify will demonstrate, that outcomes research takes interesting cases, utilizes the ability to analyze very large databases and generate new knowledge that heretofore would not have been possible. So to make my case, let me tell you about a unfortunately not too atypical circumstance when I was chief of trauma, taking trauma call at our hospital there in East Baltimore, where a 25-year-old came in a late May afternoon with a gunshot wound to both chests, to the right thigh, and to the scrotum. And you can see very quickly that this patient is in trouble, markedly hypotensive, with a blood pressure of 60, a pulse rate of 135. His depressed Glasgow Coma score is less about direct brain injury, but speaks to his overall hypoperfusion. He's got decreased breath sounds bilaterally relative to his gunshot wounds, a soft abdomen, and a large scrotal hematoma, reflecting the presence of yet another gunshot wound, as well as one to the thigh. Obviously, this is going to call for some very a rapid response. He gets bilateral chest tubes, typed and crossed with blood. Over 1 liter of blood comes out of his right chest immediately, and over 500 out of his left chest. We put a large line in his femoral vein for resuscitation of blood and blood products, and we're off and running to the operating room. I'm going to use that 7th floor elevator ride to kind of make the decision what cavity we're going to go in first. It's pretty clear his major hemorrhage, or the plurality of his hemorrhage, is coming from his right chest. And so he's going to get quickly placed on the OR table in the decubitus position. We're going to explore his right chest for hemorrhage control, and hopefully have our GU colleagues explore his scrotum after we get control of his hemorrhage. Indeed, he was very much in trouble. If you look at the first hour and a half to hour and 45 minutes after arrival, our anesthesiologists do a pretty good job of documenting just how much trouble this patient is in. A pH that gets as low as 7.03. Marked metabolic acidosis, only made worse by the fact that we dropped the right lung in order to get hemorrhage control. And so he has a pH that goes as low as 7.03, of hemoglobin, incredibly enough, that goes as low as 3. And through the first hour plus, as we're working to get control, you can see that he's in trouble. It's only about an hour after that low, that hemoglobin low, where we're able to hyperventilate ultimately let the lung back up. The hemoglobin then stabilizes around 8. The bicarb starts to improve. And so when we approach the third hour, our GU colleagues then come in to explore the scrotum, and our thoracotomy required a so-called tractotomy. That's the use of the gastrointestinal anastomotic stapler that we use in GI surgery. We apply it to the lung through the entry and exit wound of the bullet, fire the stapler, open up the tract that allows us to oversow disrupted airways and vessels in the lung. So that tractotomy for hemorrhage control, preceded the urologist's scrotal exploration, where they identified that his left testicle was completely destroyed, as well as 5/6 of his right testicle. So this debridement of dead tissue ultimately left him with about 1/12 of his testicular mass. He got 18 units of blood products. That becomes relevant when you consider the trauma literature, the transplant literature, the oncology literature, all speak to on a multivariate logistic regression analytic way, all speak to the added risk factors of blood transfusions over and above the fact of why they're getting transfused. So these developments, 18-unit blood transfusion, pH is as low as 7.03, dramatic onset of hemorrhagic shock, but would predict that we're in for a stormy course, even as we get this patient off the table. And of course, some setting you up. I'm not going to come to grand rounds and say the patient died, everyone have a good day. In fact, this patient, by 4 in the morning, later that night, early into the next morning, has completely stabilized. His base deficit has corrected. His pH is normalized. Hemoglobin is stable. And to my surprise, he gets extubated the next morning. I would not have predicted that for this patient based on markers that include the multi-system hemorrhage, his injury severity score, which allows us to quantify some of these things that I've been referring to, both physiologically and anatomically, the sheer numbers of the magnitude of his transfusions. And but for a chest tube that he had for 4 days, he might have been ready to go home 3 days after this clearly life-threatening injury. As I look back on the scan of my career as a trauma surgeon, taking trauma call at level 1 urban trauma center, seeing a large amount of penetrating trauma, I think of patients that I see with multiple gunshot wounds to the chest. There's going to be a large proportion of them that will be dead on arrival. If that bullet hits the heart, the aorta, pulmonary vasculature, cava, there's going to be another preponderance of patients who will be fortunate enough for the bullet, and while it's hard to get a bullet through the chest without hitting the lungs, but to hit the lungs and the lungs alone, a low pressure system where evacuation of blood and air allows that patient to actually recover without surgery. In fact, 80% of patients who are not dead on arrival with gunshot wounds to the right chest get in and out of the hospital without an operation, just a chest tube. And so I'm describing this morning a patient who's in between those extremes, who has potentially lethal injuries that could kill him, on the table or in the ICU afterwards, not dead on arrival, a scheme of a pattern of injury that produces concomitantly a peak physiologic insult, of hemorrhagic shock, concomitant with a dramatic decrease in his circulating testosterone. And you all have heard the saying, that's easy to say, not easy to do. That's not even easy to say. And yet here we have this patient doing so well in the early postoperative period. Now, what gives this one patient the prediction? What would explain why this patient does so well with that cascade of injuries? And that's what I want to focus on in this lecture this morning. Now, originally when Dr. Schulich and I were discussing my visit, life happens, and so that's why we're having this Zoom discussion. But my son spent last season, he's a Pop Warner, middle school, high school, college football player who was recruited to play rugby for your rugby team outside of Denver, the American Raptors. And I bring that up because I want to tell you about a philosophy that I violated, my own philosophy as a sports dad. Now Michael was just 10 years old when we came to Hopkins and took the job, and something happened when he turned 12 and 13. His mom and dad started to shrink. And this is not his high school graduation photo. That's his 8th grade graduation photo, giving him a certain advantage as a receiver. And now I don't feel like an old man, but I was kind of an old school sports dad. The lesson in our family is you're representing the name on the front of the jersey as well as the name on the back of the jersey. And so you won't see a lot of histrionics in the highlights film. I'm one of those old school parents that say, act like you've been there before. Act like you're going to be back. You're going to score again. None of this dancing and stuff. Hand the ball to the official, get back to the huddle, and prepare for the next success. That's our philosophy. You represent the name on the front of the jersey and the back of the jersey. And the reason why I'm telling this august gathering this morning, that philosophic bent of mine, is because I have to admit, just among us, I violated, Dr. Schulich, I violated my own philosophy. We're in the ICU. This patient's had multiple torso gunshot wounds, blood pressure 60 arriving, 18 units of blood, pH as low as 7.03, hemoglobin as low as 3. I'm thinking about a stormy postoperative course that could feature multi-system organ dysfunction, a systemic inflammatory response that could lead to the patient's demise. And yet the next morning he's extubated stable with a normal acid base, a stable hemoglobin. And so I took the team off the ICU after we reviewed that patient, into a side conference room, and we're jumping around, slapping high fives, and not the sort of thing I want my other patients to see. You don't want your trauma patients to see that you're elated that your patient survived and that this is an unexpected thing. And so there is something that we need to understand about why this one patient would do so well. And, it's been more than 30 years of between 4 and 8 trauma calls a month in-house. That's 360 plus months. And I could do another 30 and I won't see another patient with this pattern of injury. Multiple gunshot wounds that could have killed him, potentially lethal injuries, producing hemorrhagic shock concomitant with a dramatic decrease of his circulating testosterone. And you can actually measure his postoperative testosterone, knowing the half-life. And it makes the case that his dramatic decrement of circulating testosterone did indeed coincide with the peak physiologic insult of hemorrhagic shock. Well, we've known now for over 30 years that when you subject rats to experimental hemorrhagic shock, female rats do better, have a better survival than male rats. We'll get right into animal outcome disparity. Castrated male rats, don't ask me who thought to do this experiment first, but castrated male rats do better than non-castrated male rats subjected to experimental hemorrhagic shock, and estradiol receptor block female rats do worse in terms of survival than their non-receptor blocked counterparts when exposed to experimental hemorrhagic shock. The sum total of this basic science work, over 3+ decades ago, tells us that in lab animals, androgens have been shown to be responsible for the immunosuppression after trauma hemorrhage in males. And in contrast, female sex steroids are somewhat immunoprotective. Now, it's interesting, once you have this knowledge, we can get very, very intelligent after the fact. We may say teleologically that makes sense in terms of survival of our species. Our survival depends on the fertility of the female sex in our species. That's defined as cyclical hemorrhage. And so perhaps when we think about it, we should not be surprised that there's a physiologically based survival difference that predicts female survival superiority in major trauma and in hemorrhagic shock. And in fact, if I were to share Another case that I had from blood trauma when I was at Howard would be a 36-year-old biologic male who sustained a 3-story fall, who comes in also hypotensive, blood pressure 94/52, a pulse rate of 122, a head injury, Glasgow coma score of only 3, with evidence of injury to the face, the torso, the right arm, left thigh, and the pelvis. And while the patient didn't have intra-abdominal bleeding, had evidence of fractured left orbit, pneumocephalus, humerus fracture, multiple pelvis and femur fractures with obvious clinical indications that there was some extraperitoneal bleeding associated with that pelvic fracture. This patient in the first 2 hours is getting fluid, blood, and pressors, also has a marked metabolic acidosis, goes on the ventilator in an attempt to help to compensate for that, and is in fact a transgender patient who's taking exogenous estrogen. 6'2", 220 pounds, subcutaneous fat deposition about the hips, thighs, testicular atrophy and breast development consistent with the exogenous estrogens this patient is taking, and a hospital course that is also massive transfusion, 10 units of blood. Interventional radiology embolizes the bleeding branch off the internal iliac artery, external fixation, and pelvic traction for femur fracture in a patient who's on pressors. Again, multiple indicators from a physiologic standpoint, degree of transfusion that's going to predict major morbidity and potentially mortality in this patient. This patient also has a depressed testosterone. And indeed, by the 4th hospital day, this patient is weaned, extubated, responsive, and has normal renal function. Just 2 cases. But without outcomes research, this would be a talk about 2 very interesting cases that might point to a reason, a physiologic reason why we might see gender-based. And I always, when I have elective students that take our outcomes research elective, and I always say to my female colleagues, now shame on you for what you're thinking. I'm not suggesting that orchiectomy, castration be a part of an adjuvant treatment mode to improve the survival, but it's very interesting that the urologists for decades now have utilized transient testosterone receptor blockade in the treatment of metastatic prostate cancer, for example. And so this immediately gives rise to a speculation. What if we use the US military and affiliated institutions have performed studies when studying things such as recombinant factor 7 studies to assess for improvement in outcomes and use inclusion criteria such as 10 units of blood or more. These are 2 cases where we had that. And I'm thinking if there's a way we can assess in the literature, since we now have these large prospectively maintained trauma registries, if we see the same sort of outcome disparities, female gender superiority as it relates to survival after major trauma, then it's time to consider transient receptor blockade on a criteria of patients who are at risk from major hemorrhage. And so we did. My colleague, Dr. Hayter, was the lead author in an analysis of the National Pediatric Trauma Registry. These are my colleagues who were with me when we pursued this during my time at Hopkins, using a registry that is prospectively maintained from 93 trauma centers, 50,000 patients, entering demographic, physiologic, anatomic data with respect to the pattern and severity of injury, the survival, the length of stay, the complications. We have both anatomic and physiologic criteria. And when we look at survival by gender, recognizing the average onset of menses in this country is about age 12, you see why these databases prospectively maintained need to be so large if you're going to engage in outcomes research. Over 46,000 patients of that 50,000 had complete data, 92%. That's what it takes to get down to 700 critically injured children, stratified into pre-adolescent and adolescent, with the multivariate logistic regression analysis taking into account those factors that I mentioned: pattern of injury, physiologic factors, anatomic scores. And when we do that and compare outcomes, we see that the survival benefit of girls compared to their male counterparts achieves statistical significance only after the age of 12. And if we then do the same thing in a large national trauma database, a trauma data bank maintained by the American College of Surgeons, we see the same sort of things when we look at age, that at the extremes of age, 12 and below, 65 and above, where physiologic differences between males and females are somewhat diminished, the survival advantage of critically injured females compared to males does not achieve statistical significance. In other words, using the odds ratio, the risk of death for females compared to males, it's 8% lower for those pre-adolescents. But when you look at the 95% confidence interval, it suggests that number could be anywhere from 26% lower to 14% higher. So not a significant survival benefit below the age of 12. Similarly, the presumptive 10% lower risk of death among the group 65 and above for females also crosses one, and therefore that 95% confidence interval, anywhere from 24% lower risk of death to 5% higher, is not significant. It's only in between those two extremes where we see a statistically significant improvement in survival among critically injured females compared to their critically injured male counterparts. And so, because of outcomes research, I say to you this morning, I'm convinced. I could be taking call for another 30 years. And I'm not going to see another patient like the one I described. And yet this database, this particular early iteration of the National Trauma Data Bank with over 1.5 million patients is what it takes for us to generate knowledge that suggests that among humans, we see the same pattern that we've known about for decades among rats. And I think we've progressed to the point where we're ready to try in amongst those extreme. This patient group, this population is about 3% of the total population of patients in the National Trauma Data Bank. I've been asked, well, what would you do? Would you block testosterone or would you promote estrogen? So, well, when you get to trauma hemorrhage and gunshot wounds with 10 units of blood or more transfused, it just so happens that approaches a 95% male disease. And so it would lend itself, in my opinion, to transient testosterone receptor blockade for those small subset of patients that meet that criteria of major hemorrhage, 10 units or greater. And so that's a who. Who has, so is there a survival benefit based on physiology? I think there is. I think it's hormonal based. And I think it's pretty clear that among humans, as it is among rats, there is a physiologic based survival benefit favoring females. The question of socioeconomics differences, race, ethnicity, race being a social construct as an indicator of survival differences is another one that has taken me for a little bit of a loop in my own career. I'll tell you another story that's a Hopkins-based story. When just a couple of years after I got there in 2001, President George W. Bush came to Hopkins and wanted to give a talk about his views on healthcare reform, prescription drug benefit. There was legislation that was under consideration at the time. And As is the case when the president travels, the White House nursing office travels in advance. They will meet with the regional or local trauma center. Since the president was going to be physically inside the hospital, they wanted to meet the chief of trauma and get a look at our facilities, what our blood bank was like, where we resuscitated patients, the operating room was like, the ICU, where would the family go, where would the media go, and so forth. And so I gave them that tour of our facilities, and I suppose because I did, I scored an invite to the auditorium that day when the president spoke. I was also on call. It was a Friday afternoon, and shortly after the president left, they asked everyone to remain seated, let the president leave. And then when I left a few minutes later, it was less than 5 minutes when the trauma pager went off. And the message said gunshot wound to the flank. ETA 2 minutes. And it's something when you kind of bury yourself in details for a few days about a very important visit, it's a little funny how your mind plays tricks on you. You get that message, gunshot wound, and my instinctive reaction was, oh no, but everybody relaxed. The president didn't get shot that day. It would have been in all the papers. It was not the president of the United States. In fact, it was a 16-year-old kid from East Baltimore who in fact got shot in the flank. He had a left flank. He had a left renal artery injury. I took out his left kidney. He had the same surgeon, anesthesiologist, operating room, blood bank, ICU bed, ICU nurse that the president of the United States would have had he been shot that same day. And the reason why I tell that story is if you had asked me in 2001, in 2005, 2008, would I expect to see outcome differences, such as I just described by gender? Would I expect to see outcome differences based on socioeconomics, race, ethnicity, insurance status? I would have said, heck no. And it's interesting, Dr. Schulich, when I asked my students taking my elective, they all embarrassed me because they all say yes. They're smarter than I was. But if I was honest with you and I told you that story that I just did, I would say there's no way I would expect to see differences until we looked into it. And that's just what we did. Again, our group, Dr. Hayter, who was our first trauma fellow, joined the faculty. And then when he left Hopkins, he went on to lead an outcomes research institute, the Center for Surgery and Public Health up at Brigham and Women's. And he's now the dean of the Aga Khan Medical School in Pakistan. And with this study, looking at, again, the National Trauma Data Bank amongst critically injured patients and stratifying their outcomes by race, ethnicity, and insurance status, nearly 380,000 patients, we see interesting findings, despite what I would have predicted. As you go from your left to your right, white to black to Hispanic, insured, to the same white, black, Hispanic group, uninsured, with a white insured patient serving as the point of reference, we see that the relative risk of mortality progressively rises as you go from white to black to Hispanic amongst the insured, and similarly, even more so as you go among the uninsured. Now, I mentioned confidence interval before up to the earlier study, and I call your attention again to that. So that, for example, if you compare in this data set, the risk of death for insured black patient in this data set compared to his white insured counterpart, he has a 20% greater risk of death. It's significant. The 95% confidence interval is somewhere between 8 to 33% higher risk of death. And even perhaps more interestingly, if you look at the confidence intervals, non-overlapping confidence intervals, for example, between a black insured patient in this data set and a white uninsured patient, the 8 to 33% greater risk of death is actually less than the 46 to 64% with a 95% confidence interval risk of death among the white uninsured patients, suggesting in this data set that a Black insured patient had a better survival, better chance of survival than white uninsured patients. And I'll summarize about 4 or 5 years of subsequent papers that we've written that suggests insurance status is the single greatest associated prognostic factor that we see in any of our trauma analyses. We will not do a multivariate logistic regression model that does not include insurance status. It trumps gender, it trumps race, ethnicity, pattern of injury as the single most predictive one. And why should that be? I can tell each of you that in over 30 years, I've never known the insurance status of a patient that have coming in the door. I will take my call, I'll submit my billing, the next day or after that weekend is over, and then someone might do an analysis of my reimbursement rate of my patients that long after I've forgotten the individual patient, that may be months afterwards. And let's remember that while in our department during my 13 years of chair in our Outcomes Research Center, we've developed studies that show across a host of surgical diseases, vascular, cardiac, transplant, surgical oncology, obesity, race, and socioeconomic basis for differences in outcomes. All of those, I would argue, have something to do with access, health literacy, sophistication, insurance status, proximity to a hospital. But this stands alone. This study that looks at insured versus uninsured and the dramatic impact or association with outcomes by insurance status is a group of patients where you can say that critically injured uninsured patients gain access to the system every bit as quickly as their critically injured insured counterpart. And so what is it? If it's not access, what is it that would explain why we see such finding? Now it becomes speculative because you can't make a prospective assertion from retrospective analysis. And my postulation would be that insurance is a surrogate, perhaps a powerful surrogate for things such as having a primary care physician, knowing your hemoglobin A1C, your lipid profile, your blood pressure. We know that after the 2010 passage of the Affordable Care Act, there's a dramatic difference, at least in the 33 states that accepted a Medicaid expansion among the utility, among Medicaid patients of accessing both pharmaceuticals and Medicaid-run clinics. And so if health behaviors change, these tend to be the things that you bring to the table the night you're shot or stabbed or in a motor vehicle crash. And this study in our mind raises more questions than it answers. Do you inherit the survival benefit when you move, as was anticipated, 35 million Americans were going to move over the 7 years following that legislation? Do you inherit the survival benefit of the insured group months or so after you gain insurance? Why is it that we see? Is it we know that penetrating trauma patients do worse in general, such as the one that I started out describing? We know we see that more amongst uninsured patients. Does that explain it? Well, it doesn't. When we do a interaction analysis, we see that amongst both blunt trauma patients, insured versus uninsured, and penetrating trauma patients, insured versus uninsured, there's a significant greater mortality among the uninsured group across mechanism of injury. And again, by mechanism, by gender, by race, by ethnicity, we see survival differences, but none so dramatic as we see in the insured group. And so we believe that, and we propose as much to the National Institute of minority health and disparities, that injury is the area where we should investigate if we are interested in pursuing answers about the benefits of insurance status. And when we did that sort of thing, our grant was reviewed on the day in 2017 when the House of Representatives repealed the Affordable Care Act. Now that repeal fell one vote short. If you all remember John McCain's thumbs down vote, that repeal fell one vote short in the Senate. But when we looked at our comments from the reviewers of our application, they asked the question whether or not our proposal had relevance, a proposal that had us looking to compare state trauma registries. Well, we've gotten to the point where we can look at expected versus observed survival. You can look at it for a surgeon, for a trauma center, and for a state system, and compare that so-called O to E ratio before and after the advent of the expanded Medicaid eligibility that was seen through the Affordable Care Act. Our proposal was to compare two demographically similar states, Kentucky, which accepted the Medicaid expansion and really benefited statistically in terms of numbers of patients moving from uninsured to insured. They went from about 19% uninsured to about 6% uninsured. Compared with Georgia, that went from 21% to 19%. They did not accept the Medicaid expansion. And if we compare each state with itself as a control before and after the Affordable Care Act and across with that other state, would we in fact see improvements in the state system? In other words, if you have a better wellness, overall insurance coverage that goes from 81% to 94%. We use the term, Dr. Schulich, we don't use anymore. We use the term herd immunity, but that term has become a little toxic with subsequent developments. But an overall wellness and insurance coverage of a state that dramatically improves, does that prepare them to be more ready to withstand the rigors of trauma? And in addressing that, I'll just share with you just a couple more slides that along the category of raising questions. Who dies? When we see outcome disparity differences, we see women dying at a lower rate among critically injured patients. Why? We think there's clearly a hormonal basis, physiologic basis when it relates to gender disparities. There's clearly a difference when we look at insurance status, although it's not clear exactly the full-fledged advantages of insurance status. And when they die is also an issue. Now, we in trauma care don't typically follow these actuarial survival curves that our colleagues in oncology do when, for example, they will talk about the 2-year survival following pancreatic cancer, or the 5-year survival following colon cancer, or the 10-year survival following breast cancer. We're going out to 14 days. We have a much shorter attention span in trauma and acute care surgery. If we looked at the survival differences between whites and minorities, we see a small but significant survival difference that we see at the first 24 hours, suggesting that there's something in the pre-hospital setting that might predict why Blacks would do worse than whites. But as you go out 14 days, it's not much. It doesn't open up much. It's close to parallel in terms of the 14-day survival compared to the 1-day survival differences. When we look at gender, we said females do better. We see that difference starting at the first day. It opens up a little bit as you go out to 14 days, perhaps a little more than minorities versus whites. But the third slide is the one that I consider the most troubling slide of any talk that I give. This is the difference between insured patients and uninsured patients. Dramatic difference in survival seen on the very first day, and gets wider still as we go out to 14 days. Raising questions, I've presented this slide in talks to both professional and lay groups alike. And once a congressional staffer asked me, "Doc, what's going on in the hospital? What are you doing different?" with these patients? You know, that's a tough question that should make all of us uncomfortable. It's a fair question, but it's a pretty tough one that gets into issues about, are there differences in management and implicit bias and those sorts of things. And so, as a question that pursues answer, we believe the next step is to look at not only the differences that I mentioned by states, where we see large numbers of Americans moving from the ranks of the uninsured to the insured, but even that does not explain the race-based differences. You know, that's some of the toughest stuff to talk about in American discourse. But who, if not us, in academic surgery, we collegial debate at M&Ms and grand rounds is what we do all the time. And we have an opportunity, and this is something that we're very interested in pursuing, which is a registry that would allow us to look at differences in survival between different races and ethnicity among a group that is in fact insured, that has similar insurance coverage. A group that is largely insured, has a fairly monolithic lifestyle. When they're injured, they're treated in accordance with fairly well-established guidelines, both in terms of treatment management, clinical management, as well as transport. Despite all those good things, insurance status predictors are at higher risk of injury. And yet we have pretty good evidence that they're managed in the same way. And of course, I'm talking about the military. Who else would you see, despite those things, having a high risk for injury? Do those race-based differences, race ethnicity-based differences disappear in the military? We see acute care surgical condition outcomes, diverticulitis, appendicitis, complication differences are diminished among military. They're all are, you know, I mentioned the monolithic lifestyle. They're considered our heroes. And in the non-traumatic acute care surgical literature, we see a diminished differences in outcomes that we see everywhere else. If the same thing happens in trauma, then although our civilian system will never be exactly like the military system, but then we would have what industry calls best practices. And if they do not, race being a social construct, you now still have a very interesting finding. This is what I say to my group: the most interesting project you can do is one that it's an important contribution no matter what your findings are. Take your own bias out of it. And so we believe that is the next step for what we don't know, comparing trauma registries to assess outcome, observed versus expected death, pre and post the Medicaid expansion that's afforded through the Affordable Care Act in a state that accepted it versus the state that it didn't. And as it relates to the race and ethnicity-based differences, utilizing military database where we have across race ethnicity a consistency of insurance coverage. In fact, it's mandated. You have to be covered. You have to have a certain lifestyle. You have to have a certain fitness to even take part in the military. And that's where I believe our next direction should be as we pursue what I consider, thanks to outcomes research, an important finding that I would have never guessed. And so, do I think there's outcome differences, physiologic outcome differences? Absolutely, I do. Gender-based, based on physiology. Are there socioeconomic outcome differences? Absolutely, less well understood. But clearly, the most powerful surrogate for those differences would be insurance status. And that's what I'm dedicated to helping to find. The reason I say I'm a cheerleader for outcomes research, because without it, this would just be a talk about two interesting cases. And so, ladies and gentlemen, that's what makes me excited about coming to work. I conclude that the basic science and clinical evidence for gender-based disparities is indisputable, and that our science has improved to the point where we're now poised to deal with the difficult topic of socioeconomic differences. It's all about outcome. It's been a pleasure and an honor to present the Henry Swan Lecture. And I look forward to any questions you may have. Thank you very much.
Dr. Cornwell, Eddie, thank you so much for delivering this outstanding talk. And you know, it brings me back to our older days when I was a junior faculty member with you and learning from you. And I want you to also know that you have had a profound influence on research in these areas at the University of Colorado. So in particular, and you know, I always run the danger of not you know, remembering and presenting everyone, but we recruited Catherine Velopoulos from Johns Hopkins. I think she was there maybe a little bit after you left,
Yes.
but she tagged on to some of the outcomes programs that you helped build in the trauma world. And she's been extremely successful here and is R01 funded and has followed along the same lines of research that you helped really pioneer at Johns Hopkins. And then, of course, Rob McGee runs our surgical outcomes and applied research. And I think you had a direct hand in teaching him, at least for a couple of years before you left to become chair at Howard. And there are others too. And, you know, this has all been built from watching you and understanding all the different pieces that you had to put together to put this outcomes program together. And, you know, the other thing that you brought up a couple of times that really resonates with me, and it was taught to me and maybe to you by a common mentor that we have, who is John Cameron.
Mhm.
And, you know, he told us, you know, find a career that you really enjoy and you love to do, and you never have to work a day in your life.
Absolutely.
And
Absolutely.
I think for the most part, that's been true for me. And from what I can see, that's been also true for you.
Absolutely.
And then lastly, my comment, you know, as you know, Eddie, I'm a cancer surgeon, so I kind of put everything into that framework. And I think penetrating trauma is just like a cancer, right? And you know, it spreads, it metastasizes, it influences other you know, areas within a city and other cities. And really, the four key strategies are prevention, just like cancer, right? Well, if you can't prevent, then you need some kind of organized system so that if it happens, you get these people quickly and appropriately to the right place, the right level, and all that.
Yeah.
And I liken that to early detection.
Yeah.
And then, you know, and if you have bad injuries, you better have great therapies out there.
Yeah.
So your surgeons better be good, your anesthesiologist, your blood bank, you know, all the infrastructure that you need to take care of trauma.
Yeah.
And the fourth area is you can have all these great things, but if you don't deploy them equally to all your citizens, or if you don't have multidisciplinary care, or you don't connect the right patient to the right therapy at the right time, then, you know, what's the point in having all this? And you see all these disparities.
Absolutely.
And cancer care has exactly the same disparities.
Yeah.
And I think we have a lot of work to do in this country and in this world. But the first part of tackling a problem is to understand exactly what it is. And you have contributed so much, you know, with your 400 or so publications and all the research programs that you have led. And I really congratulate you.
Well, let's thank you. That's again, too kind. And I mean, so much of what you said resonates with me in terms of the analogies. But let me just say towards one piece, you'll get a kick out of this. Rob McGee was giving a talk a few months before I left Hopkins. I'd been recruited to Howard, had many visits, and I was thinking in my department, what things would we be able to do? And Dave Chang came with me. You'll remember Dave Chang set up our Outcomes Research Center. But sometime in a couple months before that, Rob was giving a talk at Research Day And it was a talk on comparing lung resections at university and community hospitals. And I've quoted this many times in developing, and I remember Levi Watkins asked him a question. So he was looking at outcomes, and he's stratified by patients, I believe, who had pneumonectomies versus lobectomies versus segmentectomies. And he was asked about, interesting, your main difference you saw was among the group that had lobectomies, but not pneumonectomies. And I remember his answer saying, well, part of that may just be a numbers issue. We only had 1,000 or whatever the number was, but a large number. We only had 1,000 pneumonectomies. And I remember saying, think about that. You know, you have this registry that allows you to say, we only had 1,000. The days of, you know, our center, when I was at USC, we had a large enough center. We were publishing on our own one institutional registry, and even that would not be large enough. It's the sort of numbers it takes to identify these differences that we otherwise couldn't, led the light to go on that day to that to be the next step in my career. So I hope Rob knows that talk. I don't even know if he'll remember that talk he was giving. It was a research day we always had at Hopkins, and it just hit me at the right time in my career when I was contemplating what's the next step. And I think the next step is the sort of numbers that it takes so that we can all, 77 centers contributing to a pediatric registry, even more for another large 1.5 million registry, is what it takes to generate knowledge that otherwise would not be available to us.
Yes. So Dr. Cornwell, we have a question on the chat function from Dr. Pompicelli, who runs our liver transplant program. He states, congratulations, terrific talk. Most interventions mitigating injury response must be given pre-injury. Any evidence blocking testosterone after injury works? Thanks.
That's a great question. And we don't know. We don't have that evidence. This patient that I'm describing had, obviously, the gunshot wounds are concurrent. So his hemorrhagic shock is going on at the same time, as is decrease of circulating testosterone, which, based on the half-life and the postoperative testosterone level, is occurring in that first hour and a half after injury. So no, we don't have that evidence in humans. Unfortunately, we only have it in rats. And so it's the combination of what we know in lab animals and the pattern of survival that we see in humans that leads me to speculate that there's a difference in the early post-injury phase.
Okay, well, with that, I think we'll draw this to a close. Dr. Cornwell, again, congratulations for giving our Swan Lecture this year. And also thank you for all of your mentorship, your teaching, and your leadership in American surgery. And we are also appreciative, and what a great way to start off the week. Thank you, everyone. Have a nice day.
I appreciate it. Thanks so much. Everyone have a great day.